Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
You've heard about tummy aches, you've heard about problems where you can't eat anymore because of this or that. It all comes down to digestion. And when did you last hear from a doctor that knows all about digestion? He's going to help us with some things. So I'm privileged to have Dr. Edward DEUTSCH, who is a gastroenterologist, and he is with an organization called Digestive Care. We all want our digestion to be cared for, don't we, Dr. DEUTSCH?
Well, absolutely.
So when you think about it, as a matter of fact, I just left an associate, and the person said, I woke up with a stomach ache, and I said, what are you doing for it? Well, I'm taking some tea. I said, well, just be careful what you eat, and if it continues, you better go see a gastroenterologist. So why don't we just go through, as a physician and having that specialty, why do people wind up seeing you?
From probably a whole host of reasons. Obviously, from symptoms that they have, from, we take anything from mouth to the bottom, and then the thing they don't like seeing us about is the screening for colon cancer.
Ah, okay. So now we're getting into colonoscopies, huh?
Yes.
Okay.
Yes, ma'am.
Yeah, well, that's I guess, towards the end of the thing. So someone just comes in and they've had, I guess, a stomach ache or diarrhea or bowel, Pac-Man, they can't do it. So what are the questions that you ask?
Generally, it starts off with them describing their symptoms, how long it's been going on, are there associated symptoms, history of any other problems they might have in the past, both GI or non-GI related, that may have an impact. And then a lot of times, what they've done both to help themselves, and has it worked, has it not worked?
Well, I will tell you something that and I usually don't do this, but my husband was 93 in very good health, and he had knees and hips. You're having the shoulder, but he had knees and hips, and everything was working fine. He woke up one morning with great pain in his stomach, and it turns out when we had to rush him to the hospital, he had a lower bowel, a lower bowel, it twisted. That's what the doctor said.
Right, it's called a volvulus, right, where it's twists on itself. Yeah,
right.
That's quite painful.
And I went in, the surgeon said it's very successful. He said, but at 93, he's going to have a very difficult time of rehabilitation. Why was that? And he didn't make it.
Yeah, I mean, anytime, you're talking about the elderly, things are much more difficult. Not so much even necessarily for the problem they're treating, but most 93-year-olds have some degree of other medical conditions, heart disease, even though they may not, be in severe, but they generally have some degree of heart disease. They may have kidney dysfunction, and those types of things always kind of come into play, especially in the elderly. That it's often not the primary problem that they're fixing. It's these other things that take precedent and really are the problems management-wise, post-operatively.
Well, I've never asked of anyone because I'm so glad you're on. I just was curious. How does one have a lower bowel twist? What happened? How does that happen?
Yeah, it's basically that. The part of the bowel is attached. The bowel is attached, almost like to your abdominal wall, and there's constant movement of the intestines, just to help propulse things through, and it's not uncommon for the attachment to be a little looser, and it can twist on itself and kink off the bowel, causing no blood supply to get to that bowel, and that's what causes the severe pain. And if it's not relieved, that the bowel can die, can become gangrenous.
So that's why they have to do an emergency operation.
Exactly. Exactly. Yes.
Thank you. You answered a question I never asked anyone, so I appreciate that. But
I'm sorry about your loss.
Yes, it was unfortunate. It was. Yeah. It was unfortunate because he was in very good health with all those other things you mentioned. But who knows, right? Well, okay. So let's get back to the average listener who listens to this radio show, done this for many, many years. And when you first started, were there different applications and different processes that you did as a gastroenterologist that you do now?
Well, I think definitely, I've been practicing for over 30 years, so things have changed dramatically, what we can do, what we couldn't do. I think, whether it's advances in medications and conditions like inflammatory bowel disease, Crohn's disease, which have been revolutionized from when I started training, to endoscopy, what we can do and what we can't do, through scopes that we don't have to go through surgery for, and even into what the future holds. There's experimental stuff where now they can try to go endoscopically through into your mouth, into your stomach, purposely cut a hole in your stomach, get out into the abdomen, remove your appendix, and come back in through the stomach, and you never have an incision on your outside. So there's a lot of things that are happening, that are progressing incredibly. Obesity types of treatments endoscopically and combined with surgeons, that's obviously a major issue for our country. So there's a lot of things that have changed and continue to do so.
And so is this one of your specialties when people are overweight, working on that, or?
Right. So it's a multiple modality approach. There's people, I'm sure, have heard of all the different surgical techniques that are out there. There's endoscopic techniques that are available, and that really still fall a little short from a good long-term fix. But there are a lot of newer modalities, endoscopic modalities that are investigationally on our studies going on. I think that's going to be a role, plus pharmacology, medications to help weight reduction. And I know people who are watching the news today, even they talked about there's been these things about prolonged fasting periods, getting all your eating done in a certain period. That's gotten popular and been shown to reduce weight. So there's a lot of different ways, but I think the number one problem we're facing in GI probably in this country is the obesity of our population, and there's a thing called the fatty liver, which we're now finding will eventually be the number one cause of liver transplants because it's such a problem. So
are you overweight?
No. Well,
I'm sorry.
I'm not as good as I'd like to be, but I'm still fitting into my pants. Let's put it that way.
That's great. And so, when you went to medical school, why did you choose gastroenterology as your specialty?
Well, I'll keep it clean because I have a joke of why. When you've been called a certain body part, you start to associate with that. But that's my attempt at humor. Now, really, I really, endoscopy was really just getting started, I think, and I'll never forget seeing an endoscopic procedure and in amazement. Number one, just seeing inside someone's body. Two, while they're alive, and they, wake up 5 minutes later and they're perfectly fine and walk out the door. I thought that was just incredibly fascinating.
Yeah, it sounds like it was fascinating.
And it gives you a chance to do some therapeutics, to be a quasi-surgeon, but not really a surgeon. So, we're able to do a lot of things therapeutically through the scopes. So it's not just office procedure, or office visit type of practice.
Now, we talk about heredity. So many people, when you fill out forms when you go to a doctor. So what would you be looking for if someone checks what? To see if it's maybe something they're in their genes.
Yeah, I mean, most commonly, the main thing from our standpoint is do they have a family history of colon cancer? That predisposes them at a much higher risk to develop colon cancer, and are handled in our screening protocols differently. There's many other. Trying to get a more detailed family history of different generations. There's different hereditary syndromes and things that can certainly come into play, but they're much, much rarer. I think for the general population, just having an idea of your immediate relatives and being able to utilize that to figure out who we need to follow more closely and who we follow on a more loose protocol.
So you do colonoscopy. So how often should one have a colonoscopy? When should they start, and then how often should they do it? And then let's say they don't have polyps; it's just clean. Is it?
Sure.
Tell us about that.
So two different. Let's talk about the average person who does not have a family history of colon cancer and a first-degree relative. The current this is where it gets a little gray. The current recommendations had been really age 50 that you would start. And then if you did not have any polyps, you would come back every 10 years. It really has been for blacks age 45, and I hope I don't offend the insurance commission and the insurance industry, but unfortunately, even though our literature had suggested that they should start a little bit earlier, that has not been covered by insurance, so they're still in the 50. There's the newest thing out there now is that they're now pushing for all of everybody age 45 to be starting the screening, because we're seeing colon cancer actually starting earlier. And unfortunately, only one insurance company has approved that thus far. So most of the other insurance companies are at 50. And the importance of it is that screening colonoscopies are 100% covered with no deductibles or anything like that. We can do a colonoscopy on anybody for any medical indicated reason, but in those other cases, they have a deductible that can obviously be, quite financially distressing. So it's important for us to try to get this thing passed where we can do the screening colonoscopies and have them covered for people.
Recently I had a colorectal. That's something you take as part of your stool and you send it in, and it was clean.
Right.
But how do you feel about that? Is that for someone
there's a new I think the one thing I really wanted to express on this, because I think there's a big misunderstanding about there's a particular test that's being used, not a colonoscopy as part of screening, and while it's approved, it's called this Cologuard test, where you
that's what it was.
Your stool testing from home.
Yes,
and I think unfortunately, while it's a great test, people need to understand its limitations, and I think even physicians need to understand those limitations. It's a very, very good test for determining if you have colon cancer at the current time. And even if it's a positive test saying that you could have colon cancer, the vast majority of those people don't have colon cancer. So if you had a positive Cologuard test, your next step would be get a colonoscopy to see if you actually do or you don't. So
interesting.
so that's called a false positive. I don't have any problem with that because it gets people in. The problem really stems from what's called there's a very, very high what's called false negative rate for polyps. And people have to understand, colon cancer screening is the only cancer screening that we do that we can find a lesion, which is a polyp, before it becomes cancer, remove it to prevent colon cancer. So our goal in screening is not, yes, it's to find colon cancer, but if we find colon cancer, that person is, for all intents and purposes, probably at the very least going to have surgery. If we find a polyp before it's colon cancer, we remove that polyp, we've prevented them from getting colon cancer. Everything else, mammograms, everything else is looking for an early cancer. It's not finding a lesion before it becomes cancer. So in this instance with Cologuard, if you have a negative Cologuard test, it means, no, you're right, you do not have colon cancer. But there's over a 40% miss rate for colon polyps. So a negative Cologuard test does not mean you don't have a polyp. So where we get concerned is if someone has a negative Cologuard and they say, oh, I'm fine, and then they show up 10 years later, and now the Cologuard is positive. Now they have a cancer. Did we miss our opportunity to find the polyp before it became cancerous and could have removed it? So from our perspective, I use the Cologuard test in our elderly patients and an 80-year-old where the risk of colonoscopy may start to go up, and if I can avoid having to do, I don't care if they have a small polyp, because probably by the time they develop a problem, 1,000 other things might happen. But in our younger population, a 50-year-old who has a negative Cologuard, I think we as doctors need to explain to the patient the pros and the cons of it, and then make a decision accordingly how you want to screen people.
Dr. Deutsch, this has been a brilliant conversation. I've never heard what you just said. I think it's marvelous. Let me let everyone know we've been listening to Dr. Edward Deutsch, DEUTSCH. He is a gastroenterologist, and he's with an organization called Digestive Care. And let me give you a website to get on. It's called lovemygi.com. Lovemygi.com. That's really, you helped me, so I guess that's what I have to go do, have a colonoscopy, because it's been a long time, and I thought, okay, I didn't have anything, but...
And I will make one other comment for people, because usually the procedure is nothing. Everybody has always been concerned about the preps, the prep you take the day before to get cleaned out, and they've gotten 1,000% better. So the people used to think about having to drink a big gallon of terrible tasting stuff, and that's how it was years ago. There are multiple new preps that are out there for people, much easier. So that is the biggest fear people usually have, is having to go through a prep for it, because it's gotten much easier.
And so I had gone to a hospital to have this before. You could go to a place like your centers.
Yeah,
you do it right there.
98% of them are done at the outpatient centers. So they're really, you're there. It's maybe a total time of 2 hours there. The procedure itself is generally only about 20 minutes. Spend more time just going through all the getting the IV and the anesthesia, seeing you, and everything else. But it's a 20-minute procedure, 20 to 30-minute procedure generally.
Well, Dr. Deutsch, I look forward to meeting you. This has been excellent. Thank you. It's great. And everybody, I hope you heed the warning that Dr. Deutsch gave us. Okay, well, I hope you mend very quickly and just,
so much.
Yeah, right. And so your son's going to be very happy you've been watching this, what he loves, right?
Any way you can get on your kid's good side, I guess.
Right. Well, thank you so much. Okay. All right. Bye, Dr. Deutsch. Okay, you too.